Welcome to Pediheart, Pediatric Cardiology Today. My name is Dr. Robert Pass, and I'm the host of this podcast. I'm Professor of Pediatrics at the Icahn School of Medicine at Mount Sinai here in New York City. Thank you very much for joining me for this 313th episode of the podcast. I hope everybody enjoyed last week's episode on high-sensitivity troponin. We spoke with Dr. John McAvoy of the University of Galway. For those of you interested in this interesting topic, I'd certainly recommend you take a listen to last week's replay episode. As I say most weeks, if you'd like to get in touch with me, my email is easy to remember. It's pediheart@gmail.com. Last week, I was in Rome, Italy, at the Pedirythm XI conference. This conference occurred between September 19th and the 21st at the Centro Congress Fontana di Trevi, and the local organizer of this conference was the great Fabrizio Drago. I'd like to thank Dr. Drago for giving me the opportunity to play this week a wonderful talk by the great Bettina Cuneo on fetal arrhythmias. The session that I was in occurred on Friday, and the title of the session was Fetal Arrhythmias, When is Fetal Fatal? The title of the talk that Dr. Cuneo gave, and which we're going to listen to today, is Prevalence and Diagnostics of Fetal Arrhythmias. Dr. Cuneo needs no introduction, as she is one of the foremost experts in fetal cardiology in the world and is particularly well known for all of her work in fetal arrhythmias and particularly fetal heart block. Therefore, without further ado, let's move straight on to Dr. Cuneo's conversation about fetal arrhythmias and diagnostics. I hope you enjoyed this somewhat basic but very important and comprehensive review of this very important and interesting topic.
Welcome to the fetal arrhythmia session. I'd like to thank the organizing committee and the co-chairs for inviting me to come and share with you some of the things I have learned over the years. This first session is going to be fairly basic, and I apologize to anyone in the audience who is an advanced fetal cardiologist, but after many years of dealing with arrhythmias, I wanted to share what I've done and some of the ways to make fetal cardiology really something that you can be very excited about, as I am. So we'll first talk about the prevalence of fetal arrhythmias, then how to make a diagnosis, the sinus bradycardia, tachycardia, and then I'll end with an interesting case. So we don't really know that much about the prevalence of fetal arrhythmias because lots of times the arrhythmias are cared for by our maternal fetal medicine colleagues, so they never really are noted by the fetal cardiologist. Also, sometimes the irregular rhythms, usually with PACs or PVCs, can be transient and not reported. But it's generally felt that significant fetal and neonatal arrhythmias occur in about 1 per 4,000 live births, so actually less common than long QT syndrome, for example. The most common of these significant arrhythmias are the supraventricular tachycardias, but the really important and underappreciated arrhythmias are the silent arrhythmias of inherited arrhythmia syndromes like long QT syndrome and CPVT, Brugada also. About 10% of fetal arrhythmias require treatment or continued surveillance, and we always should recognize that arrhythmia diagnosis by echocardiography is really incomplete because what we're looking at are the mechanical consequences of the electrophysiology. And I wish I had more time to talk about fetal magnetocardiogram because it's really a fascinating topic. But there are many good papers, especially from the Wisconsin group, Dr. Ron Mackay and Dr. Jeanette Strasberger, who have written extensively on this topic. I'd like to get across the concept that while most of us refer to patient with arrhythmia, the first thing we go and do is do the fetal echo, but actually you can learn a lot and hone in on your diagnosis by getting a good history, and I'm going to show some examples of this. So, for example, if you ask the mother about her history, and she's presented with tachycardia, if she has Graves' disease, even if her thyroid has been removed or ablated, she still will carry the thyroid receptor stimulating hormones, which can cause inappropriate sinus tachycardia and hyperthyroidism in the baby. And that can also lead to heart failure. If she has any rheumatologic symptoms, you might be suspicious of antiviral antibodies if there's tachycardia or bradycardia. Other medical conditions that are important, are a history of inherited arrhythmia syndrome or medications that can cause tachycardia or bradycardia. It's interesting to note that methadone can cause not only a bradycardia, but can also prolong the QT interval in both the mother and the baby. An obstetrical history of fetal loss or prior arrhythmias or congenital heart disease can also point you to a diagnosis, either undiagnosed congenital heart disease or heterotaxy. If there's bradycardia, again, the anti-Ro antibodies or inherited arrhythmia syndromes. And a family history, we're really great at asking if there's a family history of congenital heart disease, but we don't really ask about a history of arrhythmias, sudden or unexplained death, and if anyone in the family has a pacemaker or a defibrillator. And these can be clues to the diagnosis of the rhythm in the abnormal rhythm in the baby. It also helps to ask when the arrhythmia developed. If it's bradycardia and it developed less than 16 weeks, and the diagnosis is consistent with block, so a rate of about 60 to 70, you know you're not dealing with SSA antibodies because they don't cause block until much later. On the other hand, if you're dealing with tachycardia, if the baby presents at greater than 30 weeks, it's more likely to be atrial flutter, ventricular tachycardia, or sinus tach compared to AV reentrant tachycardia. If the preceding fetal heart rate was irregular, sometimes mothers come in and say, oh yeah, before this was tachycardia, before it was fast, the rhythm was very irregular, you might think that you're dealing with SVT. On the other hand, an irregular rhythm can signify and be a harbinger of Wenckebach that's gone on to a complete heart block, either in an inherited arrhythmia condition or with anti-Ro antibodies. And of course, we're all very familiar with the arrhythmias that can occur with congenital heart disease. So bradycardia and AV block occurring with congenitally corrected transposition or left atrial isomerism, and tachycardia with Epstein's anomaly or cardiac wall defects. After history, then of course we go to the echocardiogram and have to ask three important questions. What's the fetal heart rate? What's the AV relationship? And is the rhythm regular or irregular? Of all these, probably the most important one and the one that we can deduce by fetal echocardiography is the AV relationship. And we can do that in several ways. The top tracing is a color and mode of a patient who's having blocked atrial bigeminy. And I think you can see here the atrial rate is the red, that's the bottom. And then the ventricular rate is the blue. So it's really inflow and outflow using an M mode. And you can beautifully see that there's two atrial beats for every ventricular beat here, the blue, and that the A to A prime has a different time interval than the A prime to A. So this is not AV blocked, but blocked atrial bigeminy. Another thing that I really like to use is to get an atrial M mode. This won't tell you what's going on in the atrium, but it gives a very, very clear and distinct atrial M mode, which lets you see if they're PACs or if the rhythm is regular. Doppler, however, is probably the most accurate way to get the AV relationship, especially the timing of the events. So what you want to do is use a Doppler that will reflect the atrium and the ventricle. And one of the more common ways is the mitral inflow and aortic outflow, which you see here. So you see the atrial waves are on top. We're interested in atrial contraction, not passive filling in the E wave. And this shows us that the relationship is 1-to-1 and also lets us measure that AV interval, also known as the mechanical PR interval. The pulmonary vein and pulmonary artery can also be used for this purpose. Again, the artery is going to reflect ventricular contractions and the pulmonary vein is going to reflect the atrial contractions. You can also use the left brachiocephalic or the innominate vein or the superior vena cava and the aorta. And it's important to just practice this in patients who you don't really need to get such tracing, so have normal rhythm, so that when you do have a patient with an arrhythmia, you're very, very good at it. So these are just two examples of inflow, outflow, the aorta on the top and the mitral valve on the bottom, showing sinus rhythm. and then the innominate vein and aorta on the bottom tracing. What you have to remember is that you have to look at both the atrium and the ventricle going in the same direction, because it's atrial contraction that we're looking at, so there's going to be reverse flow in the vein. So we can see here that the A wave is going the same direction as the V wave here. I'm not quite sure where to point this to get it to work. So the AV relationship, we know when it's 1-to-1 is normal. If it's greater than 1-to-1, you're either going to be dealing with blocked atrial bigeminy or AV block. And this can sometimes be very, very difficult to discern the difference between the two. And what you have to do is really measure the timing of the A prime, which is the non-conducted beat, and the A, which is the conducted beat. And in the case of blocked atrial bigeminy, those values will not be the same. While in the case of AV block, they will be. And it can be really difficult sometimes to distinguish. So I know Dr. Eliason's colleagues, Dr. Sven Erik Sunnesen, has also looked at the IVRT to look at differences between the two. So I'll turn now to bradycardia. I can also stop for questions now if anybody has any burning questions they'd like to ask. Okay, so we all know that the obstetrical definition of bradycardia is a fetal heart rate less than 110 beats per minute at any time during gestation. And why the obstetricians think this is based on this graph here. You can see that below 115, so where the blue line is right here, that's the obstetrical definition, and it's because nobody in their series of patients had heart rates lower than that. So that's how they defined the bradycardia. And these were purportedly normal subjects, but of course none of them were ever tested for the channelopathies. You can also see another limitation of this definition is that we're looking only at fetal heart rates between 25 weeks and 42 weeks on the x-axis. If, however, you look at patients with genetically proven long QT syndrome who are referred based on their family history, you can see that it's not really 110 beats per minute where most of these heart rates lie, but it's less than the third percentile, which we can see by this bottom line here in this group of over 500 normals. Similarly, patients referred with arrhythmias who are known to be long QT positive also have their fetal heart rates, some are indeed less than 110 beats per minute. There is a whole lot that would be overlooked if you used 110 beats per minute for your definition of long QT bradycardia. We recently completed a study which compared not only patients which compared long QT patients from families with long QT syndrome, all of which were genetically proven or to either have long QT or not long QT. And you can see that for every gestational age in the second and third trimesters, there was a significant difference between those who were positive and those who were negative. And I don't know if anyone was in the session before this when Dr. Treibman presented Dr. Ackerman's work looking at the QT interval and using AI to determine QT interval in patients who are positive and negative. Fetal heart rate actually is just as good as that AI-generated prediction. So there are cutoffs based on gestational age, which can give us a clue as to whether a patient has long QT or not, at least in the familial forms. So we recently looked at 87 patients, 27 of whom had a family history, who presented with fetal sinus bradycardia, and of those 85, 55 had inherited channelopathies. Now, it's not surprising based on the previous work that many of them had long QT syndrome, but of interest was that 6 of them had other channelopathies not related to long QT syndrome, one of which is CPV, or 3 had CPVT and RYR2 mutations, and 3 had HCN4 mutations consistent with sinus node dysfunction. What I found especially interesting about this too is that 4 had other channelopathies, but these are not channelopathies found really in the heart, and a lot of them had to do with problems in the brain and with calcium ions. So again, there may be a connection there, and they may cause cardiac issues that we're just not really aware of. So other causes of fetal sinus bradycardia are due to anti-Ro antibodies. We always think of them affecting the AV node, but in fact these antibodies can also affect the SA node as well, leaving the patient with a junctional or sinus bradycardia. Sometimes you can have clues to these. That was supposed to play. Let's hope these play. But I don't know if you can see, even in the still frame here, but this is a patient with sinus bradycardia who also has endocardiofibroelastosis around the left atrium. The function is normal. The rate is about 100 beats per minute. Well, there we go. So you can see it even better, the brightness in the left atrium, which is a marker for SSA disease. And these are the patients who we cared for with the different variants. The patient with the RYR2 mutation also had PVCs, but had a normal EKG after birth. So we see here the patient who had the HCN4 variant, a structurally normal heart, no EFE, and just kind of a slow rate. Here's our patient with antibodies. Here's a patient who had a calm variant, so a long QT variant, and had a little bit of cardiac hypertrophy, which we've sometimes seen with the calm patients. And then the patient with the RYR2 variant, who had an FMCG showing a premature ventricular contractions. If we look at the EKGs of these babies after birth, the HCN4 has just a slow rate. The KCNH2 has a long QT variant and long QT on the EKG, and the RYR2 seen here is really completely normal. So if you're thinking you're dealing with long QT, but the QT interval isn't prolonged after birth, be sure to get other channelopathy genes tested as well, because there may be more that you need to learn about this patient. So I'm not going to spend too much time on the tachycardias because Dr. Eliason did a really great job in doing that, but SVT with a one-to-one relationship, as you see in this picture here, is pretty common. We distinguish the two, the short and the long VA tachycardia, by actually Doppler measurements. On this top Doppler, you can see the measurements on here. That's an inflow-outflow, and here's a nice innominate vein and SVC Doppler, innominate vein and aortic Doppler showing the retrograde A waves, which are of course very pronounced when you're in SVT. And here's a tracing of the ductus venosus, showing that when you have an accessory connection, that you have a lot of retrograde flow during atrial systole. That's the flow that is above the baseline here. Here's a nice picture of atrial flutter. You can see it looks quite scary in the pictures. I have a colleague who's always very frightened that something's going to happen to the baby, but it's pretty remarkable to see how fast the atrium can beat. Here's a nice color echo showing the many atrial beats in blue compared to the ventricular beats. And again, aortic and SVC Doppler showing the atrial contractions above baseline. Dr. Eliason talked about this briefly. This is the fetal atrial flutter and SVT trial, which is underway. Edgar was kind enough to give me some outcomes. The patients who in the registry who presented with SVT and no hydrops, as we see here, the majority were treated with flecainide with digoxin at a close second. Those who had atrial flutter and no hydrops were mostly treated with sotalol. SVT with hydrops was mostly treated with a the combination therapy, and they had very few patients who had atrial flutter and high drops. What he's concluded so far, and the study should be over this year, is that persistent cardioversion is obtained. And the nice thing is about his results is that the mortality of 35% with high drops, which was quoted in historical studies, in his study is actually much less. So we are making some progress, although sometimes it doesn't seem so. And the drug-related maternal safety events are very, very rare. So I'd like to just present a patient that we recently cared for that was very interesting and just apply what we've talked about to this particular case. This was a patient that presented at 32 weeks with fetal tachycardia and bradycardia. When asked when the previous heart rates became not normal, I was told the fetal heart rates were normal, but review of the OB record shows that the highest rate was 126 beats per minute at 12 weeks and was 115 to 120 at subsequent visits. And this is really a very common feature that people don't recognize, the mild sinus bradycardia that can really be a harbinger of serious disease. So then we went through the whole questions, 32 weeks, no maternal history, no fetal losses, no family history. So this was the echo on the patient, and you can see the tachycardia and the bradycardia. The function is a little bit, it's really not all that bad. The heart's kind of big though for somebody at 32 weeks. And then we see that there is some tricuspid insufficiency. Here the blue jet coming from the tricuspid valve going into the right atrium. So the general diagnosis is that an isolated arrhythmia with a normal, structurally normal heart, and tachycardia and bradycardia. So the fetal echocardiogram, looking at the rhythm, we see that the M mode here showing the atrium here at the bottom and the ventricle here on the top, showing that the ventricle is beating much faster than the atrium, which of course is pathognomonic of ventricular tachycardia. During the bradycardic episodes, we see that there's AV block, and looking at the isovolumic relaxation time, we see that that's quite prolonged, and all those go into the diagnosis of long QT. So our summary is a long history of sinus bradycardia or sinus rhythm at less than the third percentile for gestational age, negative family history, and in the third trimester, the development of more malignant arrhythmias, mild heart failure, structurally normal heart, and a prolonged IVRT, which I know Sally is going to talk about a little bit longer. So our suspected diagnosis was a de novo variant, a KCNH2 or an SCN5A variant. So we were able to do an amniocentesis on the patient, and we found that de novo pathogenic variant in KCNH2. We also did pharmacogenomic testing and found that the mother and the baby were both CYP2D6 poor metabolizers. We started her on propranolol and also oxytocin, but we converted her really on magnesium. And we kept her on magnesium for 5 weeks on a low dose. Here you can see the maternal heart rate. As we start over here, this is when she presented that on the propranolol therapy that both the maternal heart rate and the blood pressures all went down, but then stabilized. And she was really very, very stable. 5 weeks later, the baby was born. A little baby girl who was only slightly immature at 37 and 2/7 weeks with good APGARs. She had normal cord gases, and of course you can see on her ECG that it's very abnormal. So we all feel kind of differently about fetal arrhythmias. Some people are really happy to see them. Some people would run away and do everything they could not to deal with ones. But I hope after my talk you can be as excited about them as I am. Thank you so much for your attention.
To conclude this 313th episode of Pediheart Pediatric Cardiology Today, we hear the wonderful American Armenian soprano Lucina Mara, who was born in 1925 and who died this past week at the age of 99. Ms. Amara, who was born in Hartford, Connecticut, spent the majority of her long career at the Metropolitan Opera House, where she was famous for playing leading roles but also for being the consummate professional and cover, meaning she was always available for any leading singers who were taken ill. She lived in my neighborhood of the Upper West Side of Manhattan for over 60 years, and so was my neighbor. Today we hear her sing the beautiful Grieg song Ein Traum, or A Dream. I'd like to thank Dr. Cuneo for giving me permission to play this week's lecture from Pedirythm XI in Rome, and also thank the noted electrophysiologist, Dr. Fabrizio Drago, who was the local course director and who was such a wonderful host in Rome, and finally, who kindly consented to my replaying Dr. Cuneo's lecture this week. I hope you all have a great week ahead.
Little